Hello, and welcome to the Facial Paralysis and Bell's Palsy Foundation presents Neuromuscular Retraining for Facial Paralysis and Synkinesis with Jackie Diels. I'm Lisa McKinley, Director of our foundation, and I'm being assisted today by our San Diego support group leader, Brian April.
Hello, everyone.
Hello, Brian. Thanks to everyone who's logged on today. Due to the wealth of information that Jackie will be sharing with us, we will not be taking live questions during the event. However, if you have questions after this presentation, you can email them to us at facialparalysisfound@gmail.com, and we'll have Jackie answer them probably in a follow-up session in a couple of weeks. Also, since we have a wealth of people I know from all over the country and even the world, if you are from another country, please go ahead and under the chat box, go ahead on the right, go ahead and type in what country you're listening from. I would now like to introduce our speaker today. Jackie Diels is a leading authority in the field of neuromuscular retraining, which is a non-surgical therapeutic approach to the treatment of facial paralysis. She received her degree in occupational therapy at the University of Wisconsin in 1985 and began her career there at the Neuromuscular Retraining Clinic in 1986. Jackie has authored book chapters, articles, and she also trains other therapists both in the U.S. and internationally. Jackie is currently in private practice, and we are honored to have her here today. So I'll now turn the webinar over to her.
Thank you, Lisa and Brian, and I'm honored to be here today and share this information with everybody. And I was just telling Lisa and Brian that the more people who know this, the better. And so welcome, and let's get started. Cicero said the face is the image of the soul. The face is the music to our being. The face identifies us as who we are. And it tells people what our emotional state is. Our face communicates with people. Here's one of my patients. Her name is Susan. And here you can see Susan 3 months before her acoustic neuroma surgery on the left, out having a good time at a bar with her friends after work. And here she is on the right, 5 years after her surgery. So those of you who are listening in, who have had this happen, I don't have to tell you what the devastation is, what this feels like. I do want to let you know, though, that if you're thinking that this is just a cosmetic problem and it's just about how it looks, I want to let you know that facial paralysis, although there are cosmetic things that happen with it, facial paralysis is a communicative disorder because 80% or more of our interpersonal communication is through facial expression. We don't even think about it. It's so basic to our humanness. We never ever think about it until something like this happens. And so I've had people who've come into me and said, I don't know why I'm so vain. I never used to be vain like this. This has nothing to do with vanity. This has to do with our being human and being able to communicate with other people. So today, these are the topics that we're going to discuss. I only need about an hour for each of these bullet points, so we should be done by 10 or so tonight, I think, my time. I'm just kidding. So after an introduction, I'm going to talk a little bit about the causes of facial paralysis, and we're going to get very deeply into the anatomy of the facial neuromuscular system, the difference between flaccid paralysis and synkinesis, the different treatment categories, and the retraining process for each, and then a summary at the end. So I mentioned communication. So what do we need for communicative facial expression? Well, we need to have a certain amount of strength so that the muscles can flex and move. We need to have mobility of the soft tissue. If the face is cramped or if it's tight for some reason, we won't have enough mobility to move into the expressions that we need to create. We need precise coordination. As you'll see in a little while, there are multiple muscles that make up different facial expressions. And so we have to be able to coordinate them accurately in order to have the expression that we desire. Facial expression is mostly unconscious and it's spontaneous. We never think about it. We never, in our real life, we're never looking at ourselves when we're communicating. And it isn't until something happens that we have to sit back and say, oh my gosh, I never used to think about it. Now what do I do? And I also wanted to make a point that movement is not the same as expression. So I'm sitting here and I can move my face in all sorts of ways that are not necessarily expression. It's just movement for movement's sake. And what we want to do in this program in facial retraining is to bridge the gap between movement and emotional expression. The facial retraining program was first established by my mentors at the University of Wisconsin, Drs. Baki Rita and Richard Ballier. They were both pioneers in the field of brain plasticity in rehabilitation. And I was blessed to be able to be mentored by both of them for the first 5 years of my training. The program was devoted entirely to the treatment of facial paralysis caused by a disorder of the facial nerve, as opposed to a stroke, for example. And in that time, since I began in 1986, I've treated about 25,000 different patient sessions. It is all that I do. It's all I know. And that limits me in a way, but in another way, it's just been amazing. So the retraining model is based on coordination versus strength in the face, accurate control versus exercising, precision versus trying to max out the movement, and this concept of music versus noise. You can pound on the piano keys as hard as you want, and you get plenty of strength to do that, but it doesn't create music. It doesn't create Chopin. Chopin is different than Beethoven, and both of those are different than the Beatles. And so what we want to do with the face is be able to create that music of our emotional being. Facial paralysis is caused by a number of different things that impact the facial nerve. And I'm sure that all of you on the call know about these already, but I do want to go through them. So the first one you see is the cause is a benign tumor that grows on or near the facial nerve in the brain. Acoustic neuroma, also known as a vestibular schwannoma, is the most common. Meningioma and other skull base tumors. Viral causes of facial paralysis, Bell's palsy, Ramsay-Hunt syndrome, which is also known as herpes zoster oticus, which is a form of shingles that can affect the inside of the ear or inside of the mouth and thereby cause damage to the facial nerve. Salivary gland tumors, trauma, at different kinds of motor vehicle accidents or other types of injuries of that type to the facial nerve. Mostly it's to the skull. Skull fractures can cause damage to the facial nerve. Lyme disease, and that's very prevalent in my area of the country. Congenital paralysis, so there are children who are born with paralysis from birth. And then, as I mentioned before, people having strokes. People with strokes are not appropriate for retraining because the damage in a stroke is to the brain itself, not to the nerve that connects the brain to the muscles. And I'll be talking about that in just a moment. So let's go through the anatomy. Just to get us all on the same in the same frame of mind, I like to describe the facial neuromuscular system as the electrical circuit that it is. So we have here a bulb sitting on a table, and you can see that the bulb is plugged. The bulb is plugged through a wire into the generator, and the generator is behind the wall. The wire connects the generator to the lamp itself. So this is where the electricity flows from the generator through the wire and into the bulb. There can be injury to this system in any one of these three places. For one thing, maybe the generator's out, or for whatever reason the electricity isn't being generated behind the wall. The next thing that can happen is the wire that plugs in can be cut or twisted or unplugged. And then the last thing is the bulb. You know, we all have bulbs in our lamps that eventually burn out. They fizzle and burn out. So the generator would be analogous to the brain. And what we see here is a cross-section of the part of the brain that produces movement in our body. And one thing that I think is very interesting about this cross-section is it shows how much of the brain power is used for each area of the body. And you can see that by far the greatest amount of brain surface is used to move the face. Here we have movements. You see the hand and the fingers, and then you see the tiny little arm and torso and the tiny little butt and so forth. I believe that so much of brain power is devoted to facial movement because of the complexity of the face. When we take the brain out of the top of the head and flip it upside down on a table, it will look like this. I am not going to demonstrate that live today, but maybe in a Facebook Live we can do that later. Just kidding. Anyway. All right, so we see the bottom of the brain. At the bottom of the brain, there are 12 sets of nerves called cranial nerves. And these nerves provide function in the body, everything from smell to sight to moving the eyes to feeling the face to moving the tongue and the shoulders. We're going to hone in today on nerve number 7, which is the facial nerve. And nerve number 7 is the green one that's located right there. As that nerve comes out of the base of the brain, it goes through a bony canal, and then it comes out from the back of the ear, and it branches off into many branches. There are between 6,000 and 7,000 individual nerve fibers within the facial nerve, and they connect to different functions. So the one that we're most familiar with is the movement of the face. So they connect to the movements of the muscles of facial expression and to a movement of a little muscle that's inside the ear called the stapedius. And the stapedius dampens sound that comes in toward the ear. So for some of you who've had Bell's palsy, for example, early on you might have had a sensitivity to loud noises or a fluttering, sort of a weird feeling / sound inside the ear. And that's because that stapedius muscle is not functioning early on because of the paralysis. The facial nerve also provides special functions in the body, and those include the production of tears through the lacrimal or tearing gland, and you can get either decreased tear production causing a dry eye or increased tear production causing the eye to drip uncontrollably. It also goes to some of the salivary glands in the mouth, and often people will get a dry mouth after facial paralysis. And it also goes to the front 2/3 of the taste buds on the tongue that mediate the different flavors that we can taste: sweet, sour, salt, and bitter. And so some of those are out of commission with facial paralysis, and people will often complain of a metallic taste in their mouth. The muscles of facial expression we'll consider as sort of the bulb. And the facial nerve controls all of these muscles, and there are 23 plus muscles on each side of the face, plus the orbicularis oris, which is the muscle of the mouth. Facial muscles just move the skin of the face. So this was a revelation I had in the middle of the night one night. Those of you who know me know what a geek I am about this. But I woke up and I thought, my goodness, these are the only muscles of the body that actually just move skin. They don't move bones around joints or lift heavy objects. They just move skin. And skin can be moved pretty much in any direction. One other thing that's very different about the facial muscles is the fact that they receive emotional signals from the brain as well as voluntary and spontaneous signals. So they are directly connected to the emotional centers of the brain. When you're sad, your face will show it. When you're stressed, your face will show it. When you're happy, your face will show it. In contrast, I can flex my bicep all day long and it never looks happy or sad. It always looks the same. As we get started on looking at the muscles in more detail, I want you to notice that on this diagram, each muscle has an arrow that points in a specific direction. The arrow points in the direction that the skin moves when that particular muscle flexes. Where are the muscles located specifically? Until something happens to your face, you never think about it. We don't really know how our face moves. We just assume we know, but we don't really know the anatomy. Where are the muscles located? How do they act on the skin? What function do they create? How do they coordinate to create different expressions? How does the unaffected side of the face feel as it moves? How is that different from how the affected side feels? So let's delve in here. Frontalis muscle is the muscle of the upper forehead, and when that muscle flexes, the eyebrows go up. You guys can all do this along with me and with my niece Sarah here. Corrugator, you can see corrugator here, the arrow points down. This muscle, when it flexes, brings the eyebrows down and together toward the bridge of the nose. Orbicularis oculi is the eye closure muscle. It is a sphincter type of muscle that goes all the way around the eye, and when it flexes, it closes the eyes either softly or tightly. And here is a picture of one of my patients who has paralysis on her right side, and you can see that her eye closure is impaired. The smile is the most misunderstood of all of the movements because we think we smile with our mouth, but in actuality, we don't. There are two muscles, two primary muscles that smile, and they are located in the cheek. And these are the initials ZYJ and ZYN, and you can see here that they're located in the cheek. The bottom of the muscles connect to the corner of the mouth, and when they flex, they raise the corner of the mouth. But the corner of the mouth doesn't make the movement, it just goes along for the ride. And here's Sarah again, and here she is with a closed smile and with an open smile. And so I want to show you just one way to determine whether or not your smile muscle is working, because we tend to always look at the corner of the mouth to see if we're smiling, if our smile is working or not. But what I'd like to show you is right now you can't see my mouth at all. Am I smiling or no? And how about now? And how can you tell the difference? So hopefully you can see that my cheeks are flexing and now they're not. And that is one way to determine whether or not the smile muscle is basically alive or dead. Now, what's happening at the corner of the mouth is mediated by some other things that go on in the face, and we'll talk about that in just a little while. Whoops, there we go. The orange muscles here are called the levators, from the same root as elevator, and what they are responsible for is lifting the upper lip into a snarl. This muscle, risorius, is the smirk muscle. It pulls the corner of the mouth back toward the ear. Orbicularis oris is another sphincter type muscle, and this is the muscle that moves the mouth. The mouth, as you can see from the arrows here, the mouth moves in towards center. It does not move out. So the movements that the orbicularis oris creates are lip press, lip contract, pucker, and lip protrusion like a whistle. So all of the lip moves the mouth in toward the center. The depressor anguli oris, which is the DAO in the corner here, is the frown muscle. This muscle, when it flexes, pulls the corners of the mouth down as though something is sad. The one right next door is the depressor labii inferioris, and that muscle pulls the lower lip down to show the lower teeth. And I think it's very interesting in the face, even though these two muscles are so close together, that they have such different functions. The DAO does this, and the DLI does this. Very different functions. The mentalis muscle is the one in the middle. You can see the arrow points up here. When this muscle flexes, it pulls the chin up and elevates the lower lip. And for those of you who have dimpling in your chin after Bell's palsy or acoustic neuroma or whatever, facial paralysis, may find that you have a little dimple in your chin, and that's caused by contraction of the mentalis muscle. The buccinator is a muscle that we don't see from the outside. It's located in the mucus lining on the inside of the mouth. And that muscle, when it flexes, pulls the inside mucus lining tight up against the teeth, and it helps to manipulate food between the two sides of the mouth while you're chewing. And the expression I've read is something like smug satisfaction. The platysma muscle is also one that we don't think of as being a facial muscle because it lives on the neck. So the platysma muscle, you can see the arrow points down. When this muscle flexes, it pulls the corners of the mouth down and out. This is a look of anxiety, dissatisfaction, or suffering. There are 4 basic treatment categories when working in neuromuscular retraining. And one is flaccid paralysis. And that's sort of what we think of when we think of paralysis. The face is hangy, it's drooping, nothing's moving. And then we have paresis. Paresis is where movement is just starting to come back a little bit. It's just beginning to get going. Synkinesis refers to abnormal movement that occurs when trying to make a normal movement, and we'll be talking quite a lot about that. And then the last category is post-surgical reanimation or reconstruction. So after facial nerve injury, there's a typical sequence that occurs if recovery is delayed. And so it goes from flaccid paralysis. So here we see this young gal 10 days after acoustic neuroma surgery, and you can see that she has quite a flaccid paralysis of the right side of her face at 10 days. And here at 2 months, it looks like things are just a little bit improved, right? You can see the lip is up a little bit more. At 4 months, things are looking quite good. We have a fairly good smile, really good smile, actually. Things are really on the mend. At 6 months, things look pretty good. And then at 14 months, I get the phone call that says, Jackie, I was getting better and better and better, and now I'm getting worse. And so this is what we see at the initial evaluation of this gal. And so what happened between 4 months and 15 months? At 4 months, we have a bigger smile, even though if you look at how much the cheek ball is contracting, we have less contraction on the right side than we have on the left side. And so even with less contraction, we have a fuller smile than we have here at 15 months, where you see we have a good cheek ball. So what has happened? Well, it depends how you look at it. So at first glance here, what do you see? Some of you will see a vase, a black vase in the middle, and others of you will see two faces on either side of the vase. And you can, once you know that you have both of those things, you kind of can flip-flop between the two. Is it a vase or is it two faces? So what do we see? Looking at these two people at first glance, it looks like they have exactly the same thing. In both cases, their right side is down while they're smiling. But let's take a closer look. In the gentleman, you can see that he has quite a droopy face. There's no bulking in the cheek. The eye is hanging quite low, and there's no expression. The eyebrow is way down, almost to his eye. And when we look at this gal, we see something entirely different. She has a big cheek ball. As a matter of fact, it's so big that it's actually shiny. You can see that. It's very large and tight. It almost looks swollen. And then you can see that the eyebrow is actually higher on this side than it is on the other side. And then there's something going on with the eye. There's something going on with the eye. Let's take another look. If she's got such great cheek ball and smile muscle activity, why isn't the corner of the mouth going up? So let's take a closer look. Here you can see quite clearly, if you look at her neck, that you see all of these cords coming down. This neck muscle attaches to the corner of the mouth. And if it flexes, it pulls the corner of the mouth down at the same time that she's trying to pull the corner of her mouth up. It's kind of like a tug of war going on between those two muscle groups. And here, this gentleman, you can see there's really nothing unusual going on in his neck. It's very soft. And so now, when you take another look, when you look at this gal with different eyes, you can see that maybe it's not that it's not going up. Maybe it's actually being pulled down rather than drooping down. And that's the difference between flaccid paralysis and synkinesis. Synkinesis can masquerade as flaccid paralysis, but it really requires you to take a very close look at what's happening with the individual muscles and the individual areas of the face. And here we see both of these people puckering their lips. And the gentleman has literally nothing going on this side of his face. But if you look at her, you can see it looks like the corner is not coming in toward the center. But what is happening is that her neck muscle is pulling out and down, and there are several other muscles. If you look at her smile muscle, you can see that it's actually contracting as well. So internally, she's actually smiling and pulling her neck down at the same time that she's trying to pull her mouth in toward the center of her face. You can't move in two or more directions at once. So when do we begin retraining? And here I've gone back to the different causes of paralysis to talk about this in a little bit more detail. So after an acoustic neuroma resection, all of this depends on how much damage was done to the nerve during surgery. The surgeons they're so hyper aware of maintaining that facial nerve without any injury at all, but sometimes it does happen. And so typically we can begin to start retraining at 4 months to 9 months after surgery. Sometimes it's a little bit longer than that, depending on the severity of the injury. For people who have Bell's palsy or Ramsay-Hunt syndrome, we know that 85% of the time, these people will recover completely and spontaneously with no intervention, no therapy, no nothing, within 3 months. So 85% of the time we get full recovery without any therapy. And so we let that recovery process take place and not do any therapy until after that time. This is kind of like, it's kind of like if you break your leg goes into a cast and you wouldn't dream of exercising it until the bone has healed and the cast has come off. Well, something sort of similar happens in the facial nerve. If that nerve, the wire that connects the brain to the muscles, has become crimped or compressed by swelling that occurs from the viral inflammation of the Bell's palsy, for example, that nerve will not be able to transmit the electrical signal from the brain to the muscles, and no amount of exercise will get it to move. It's like if you've unplugged your lamp, how many times do you have to flip the switch before the bulb goes on? It will not light until that nerve starts communicating with the muscles again. So we let the healing process take place. For salivary gland tumors, typically it's 3 to 6 months. For trauma, that is completely variable depending on the extent of the injury. Lyme disease runs more or less along the same course as Bell's palsy and Ramsay-Hunt syndrome, so usually we wait 3 to 4 months. For children who are born with facial paralysis, depending on the if it's a complete or a partial paralysis, often they'll undergo some reconstructive surgery before we work with them. For girls, we begin no sooner than age 8, and for boys at age 10. Sorry, guys. There's a certain level of maturity that has to take place before people can become really engaged in this process. It's very much of a cognitive thinking process. And then for the surgical reanimation patients, it depends on what procedure was done. And I'll be talking about a couple of procedures very briefly toward the end of the program today. I think that would be another nice webinar to do later on, perhaps. We don't use electrical stimulation at any point in time from the onset all the way through the end of treatment with facial paralysis. There are no research findings that show that it is effective in treating paralysis. It may interfere with proper nerve healing. It may reinforce abnormal movement patterns. There's very little good research that has been done in this field, but what we do know is that it doesn't train function or expression, and it doesn't generate that emotional feeling that's necessary to create normal facial movements. And so if there's any possibility that it can be detrimental, and there's no evidence that it's positive, we don't use it. So for in the flaccid paralysis, we are concerned first and foremost with eye care, making sure that the eye is healthy, that people are using lubricants, drops, and seeing an ophthalmologist as they need to. Really keep that eye well protected. We don't want anything to happen to the eye. The second thing we do is gentle stroking for sensory awareness. So when the face is flaccid, it's not giving signals to the brain that there's movement going on. So we want to manually give signals to the brain that that side of the face is still existing, so the brain doesn't forget about the face. So just gentle stroking, just to feel, tell your brain, feel, can you feel the face? Just keep in contact with the face. It doesn't stimulate muscle contraction in any way. And in an animal study, it showed that it may improve the nerve healing process. And then, as I mentioned before, let it heal. If there's no innervation, if there's no nerve function, then no exercise is helpful. You have to remember that the lack of movement is due to that lack of electrical connection, not due to muscle weakness. I tell people to pay attention to what the normal side feels like so the brain doesn't forget how to move. And then we begin retraining when muscle tone increases or we start to see small movements beginning. And here's Paul, and here we see him at onset, well, a few weeks after onset, actually. No, 2 months after onset, sorry. And here he is at 2 months after that. And he came in between session 1 and session 2 and said, Jackie, it's not getting better. It's not getting better, because the human eye cannot see the difference between session 1 and session 2. But I think all of you watching this can see that certainly this has improved over the initial session. And so it's very helpful to have photographs. I take photographs of people every time I see them. And we make comparisons all the time to show the progress. And then in May, he looked like this. And so he had good recovery and was very happy with his progress. I will say that most of what you see here is spontaneous recovery. It was somewhat delayed, but it's mostly spontaneous recovery. So I'm not going to take credit for this one, but he did very well with retraining. Some tips during the flaccid paralysis stage, and most of you probably know these things already. I talked about eye care, drops and gel. You can use protective barriers to especially protect yourself from cold and wind. For oral care, cutting food in small pieces and chewing on the unaffected side. The placement of the glass, placement of the straw, reduce the speed of eating and drinking. And for food pocketing, use good oral hygiene, brushing your teeth after every meal, and using a water pick to get the food that's stuck out of there. If you have nasal collapse, using breathe right strips is very helpful. And then for people who have sensitivity to loud noises, use earplugs. Paresis is when the tone of the face is just beginning to improve, and then we begin to see movement. Symmetry is increasing, and there is no synkinesis. And so this is a patient about a year and a half after surgery, and this is the first day of treatment. And after instruction, and the instruction includes where are the muscles located and how do they move, because we're not aware of that. On day 3 of her training, a couple days later, this is what it looked like. And it looks like this is a miraculous healing, but really all this was training the brain how to find the address of the muscles. So her muscles were in there. She just didn't know how to find them again after the injury. And that there's a lot that goes into that with the retraining process. How do we find those muscles again? Synkinesis is abnormal synchronization of facial movement that occurs when muscles other than those intended contract at the same time, and it results in distorted expression. We think it happens because as the nerve heals, it attaches itself to other muscles than where it originally was placed. And so when the brain sends a signal to a muscle to fire, another muscle is firing at the same time along with it. When we suppress the abnormal movement, we decrease the distortion of the face and improve the coordination and the functional movement patterns. There's a lot of misunderstanding with synkinesis. This again is a nerve injury, not an orthopedic injury that's due to wrong movement as opposed to weak movement. It can be due to a lack of mobility, where the muscles of the face get very tight and they can't move. There's a lack of coordination, but not necessarily a lack of strength. The misunderstanding of this can lead to really ineffective therapy where people are trying to move their muscles as hard as they can, and the harder they move, the more they become distorted. Neuromuscular retraining process is quite counterintuitive because in a lot of ways, when we're talking about facial movement, increased strength does not equal improved motion. And we'll see some examples of that in a little while. There are two issues that are separate but related when it comes to synkinesis. Number one is that people get hypertone. It's almost as though the facial nerve overcorrects, and so the muscles overcontract. And even at rest, people can get this tight appearing face. And so we need to take care of that contracture and tightness before we can even work on coordination at all. If you have a tight muscle, if you have a cramp, a Charlie horse in your leg, for example, and you were planning to go for a walk with your neighbor, you wouldn't call your neighbor and say, hey, Susie, I can't go for a walk today. My leg is paralyzed. You would say, I can't go for a walk. I've got a cramp. And so first we get rid of the cramps, and then we can start working on the coordination process. To get rid of the cramps, we do a variety of what we call soft tissue mobilization, stretching, massage, but it's not topical massage. It's really stretching and traction on the various muscles, and using heat. We have to analyze the vectors of pull. So looking at which muscles are contracting out of sequence. So in this lady, what we're looking, she's smiling. You can see she's had Bell's palsy on her right side. And what we've done is we've analyzed and diagrammed the muscles that are active. So the green arrows indicate the muscles that we want to flex, and those are the smile muscles. And you can see that they're activated on both sides. The right one is even more strong, it looks like, and a little bit hyperflexed than the left side. But all of the red arrows indicate muscles flexing on her right side that are not also flexing on the left side. And so when we look at this, we really are looking for isolated, appropriate movement. More in the face is not better. And because all of these muscles move skin, and they're moving the skin in a direction other than where we're intending to go, it causes a distortion, and it restricts the ability of the smile muscle to pull. So my question to her was, which side is actually moving more? And you can see that her right side, her affected side, is actually moving way more than her unaffected side, which is kind of strange and counterintuitive when you think about it, because if this is her paralyzed side, how do we wrap our brain around the fact that that side is moving more, but it lacks coordination? It's like she's pounding on all the keys. I mean, she's not doing it on purpose, of course, but it's like all the keys on the piano are being pounded, and it's not music, it's just movement. To train synkinesis is a very complex issue. We use small movements because small movements mimic normal expression. So I'm on a webinar right now, and I'm hoping that my face is appropriate, and I'm assuming it is. But I'm not sitting here and saying, I'm so glad all of you joined me this afternoon. It's so great to give you this information. We don't move our face like that. We move our face subtly. And so I can sit here and look at all of you, and I can't see you, unfortunately, but you can see me. And if I make one tiny movement, what have I just indicated to you? What emotion did I express? What did I communicate? Distaste, disgust, irritation? How much did I move? 5%? Maybe not even that much. So normal facial movement that we read in each other is very small, and it's very subtle. It's not big. And I've never had anybody come into therapy and say, Jackie, I really want to get super uber human facial strength. everyone says the exact same thing, and you all know what it is. Everyone comes in and says, I just want my face to be normal. And so that's what we're striving for. And because we're not really familiar with how our face moves in a normal way, because we never pay attention to it prior to paralysis, we kind of have to take a step back and say, what is normal in the face? Normal is little. Normal is isolated. Normal is functional. And so we do small movements to relearn the normal movements of the face, not big, super hard movements. We move slowly so that our brain has time to learn a new pattern. If you're learning a new piece on the piano, you don't just sit down and play Beethoven. You go slowly and you learn the fingering, and that's what we do in the retraining process. We learn how to keep the synkinetic muscles quiet. In other words, we pay attention to what not to move as much as what we want to move. And in doing so, we're training the brain to accurately find the address of the appropriate muscles. Where are they located? How do they move? We use sensory feedback as opposed to mirror feedback, because the eye doesn't see accurately. When looking at the smile, if the eye is looking at the corner of the mouth and it sees that the corner of the mouth doesn't go up, it automatically assumes there's weakness there. It never assumes that there's something else pulling down on the corner. And so going by feel, people can really begin to, by comparing the two sides, get a sense for what's acting wrongly on the affected side versus the unaffected side. Paying attention to how the unaffected side feels, not looks, to be able to accurately model the correct movement patterns. And I cannot, working with a well-trained facial neuromuscular retraining therapist. This is not something that we learn in school. This is a specialty program, much like a vestibular retraining that people get after they get out of school. And it is a very different system than what therapists typically learn in their curriculum. And here's Emily again, and we see her a year. We see her at about 2 years or so after her Bell's palsy at her initial evaluation, and then we see her a year after that. And so you can see she has better movement. It's not perfect. It's never perfect through retraining or through surgery. We get it as close as we can. Here is Susan, who you saw earlier, and this is her before surgery, and here she is at her initial evaluations, 5 years. I did not see her until 5 years after surgery. At that point, after working for a number of months, we pretty much discovered that retraining wasn't going to be an option for her. We were not getting any kind of movement, and we think that her nerve was probably cut during her surgery. But we were able to get her connected with a facial plastic reconstructive surgeon who did what's called a masseteric muscle transfer. And here's the picture she sent me. This is 5 years later. This is a picture that was an article that was done in her local newspaper. You can see this little fold here, and she sent it to me. And she was very happy with her outcome. They were able to open her eye. And in order to get this smile, she is biting her teeth together. And so she needs to bite in order to get the smile. But she was very happy with that outcome. Here's one of my patients. Her name is Jenny. Jenny had a severe injury to her facial nerve where she lost her facial nerve, among other things. 2 years after her injury, she had a tongue nerve, she had a jaw nerve hooked up to her facial muscles. And the video that you just saw, let's see if I can play it again here. This is the very first time that we saw movement. She's biting her teeth together. If you look closely at the right corner, you can see a teeny bit of movement. And this is 5 months after her surgery. teeny bit. There you go.
Release.
And then she's laughing because we were just so excited about it. And then here she is 5 months later, and this is her facial movement. Now she is biting to make this movement happen.
Back teeth bite down.
But you can see how much that movement grows. And so now what we're working on is getting more symmetry in the movement and helping her brain learn
without using the left side
how to make this movement without biting. Now look at that. She's doing her right side by itself and then matching it with her left side. And so she's doing very, very well. We do use botox with facial retraining that we inject in very key areas of synkinesis. We have to be very careful about where the botox goes. It allows for increased range of motion by reducing the action of opposing muscles that are pulling out of sequence. We think that it does assist with improving the learning process, and this really has to be administered by a doctor who has experience working with botox for synkinesis, not just for cosmetic uses, because the application of the botox is quite different. And here's this gentleman 3 weeks after he received botox, and you can see how by putting the botox in the neck, it eliminated this downward neck pull, it eliminated a lot of the eye pull, and he's got much better function after that. The frequency and duration of treatment really is determined on an individual basis, but the goal is for the patient to become their own best therapist, because they really will learn what their face is doing and how to manage it with first instruction and then taking their program to the next level on their own. We estimate that 90% of the treatment is completed by the person on their own at home. I videotape patients periodically and photograph them every single session. We find that people improve 1 to 2 grades on this House-Brackman scale that many of you may be familiar with. Basically, it means that if somebody comes in with 40% function, they may leave the program with 60 or 65% function, and so forth and so on. We find that gains that are acquired through treatment are retained even after people stop doing the program, and there are clinical studies that are currently underway in multiple centers around the world. So we had a question in sort of starting to wrap up here. We had a question that came in that I wanted to address. And so you can read the question here. I'm 7 months post-op, grade 5-6 paralysis initially, with recovery showing after 6 weeks. Now I'm dealing with synkinesis, tightness in the eye and mouth and nose, the eye closing slightly with chewing and tasks like spitting toothpaste, etc. Are there any exercises besides stretching that I should be doing at this stage of recovery? So here is, I put this on here because one thing that you'll notice in any of my writing or my websites or in the webinar is that I don't give lists of exercises for facial paralysis and synkinesis. And the reason is that when you look at the complexity of the 23 plus muscles on each side of the face, the muscles that can move skin in 3 dimensions, that create 2,000 plus facial expressions that are subtle and that communicate emotional states, that require precise coordination, that are effortless in the normal face. It is truly impossible without actually sitting down and doing that individual vector analysis with people to say this is the exercise that you should do. I don't actually even use the word exercise. I use the term movement coordination pattern, because exercising the muscle to increase its strength will not improve synkinesis. And I hope that through the explanation that I've given up to this point, that that's clear and why that's clear. Increased strength does not increase function. So I can smile, and let me try doing this for you. So if I smile and I flex my neck muscle at the same time, even though my smile looks fine, is it? If I relax the neck muscle, watch. So the skin moves in whatever direction is pulling it. If I'm pulling up on my fabric, the skin is like fabric, right? If I pull up on the fabric, it pulls up. If I pull down on the fabric, it pulls down. What if I pull up and down at the same time? Which direction will my fabric pull? It stops. It stops. So going up and going down at the same time restricts motion. If I flex my buccinator muscle at the same time that I'm smiling, I can have the best smile in the world. But the tightness here doesn't allow the mouth to open. So I can have a good smile and flex and it closes. Or if the depressor angulioris is flexing at the same time while I'm smiling, it'll look like this, which is an unpleasant look. It's not happy or sad. It's important to remember that not only do the facial muscles have a biomechanical pull, and one muscle can't substitute for another. My forehead muscle cannot ever substitute for my smile. They not only have a biomechanical pull, but they have an emotional signature. So sad is never happy. And if I'm happy, biomechanically, it goes in one direction. If I'm sad, biomechanically, it goes in another direction. But emotionally, it also goes in those directions. Happy, sad. And what does happy and sad together look like? It looks like this. And so in order to give people an accurate program, everyone has to be evaluated. Everybody's face is different. Everybody's healing is different. In contrast to this, oops, hang on. Whoa, hang on a second. In contrast, we have the biceps and triceps muscle. These are skeletal muscles. In about the same amount of space as between the forehead and the bottom of the neck, we have these two muscles in our upper arm. These two muscles move bones around a joint. One muscle goes this way, bicep, and then tricep goes this way. There's only two movements in this amount of space. Two movements, in and out. The arm lifts objects. There is no emotional content. The motion of the arm is limited by a biomechanical joint. It only allows motion in this plane, in and out. It doesn't allow motion in 3 dimensions. And increased strength in the arm does equal increased function. If I get my arm stronger, I can lift heavier objects. So the long answer to the question is are there other things that you can be doing? And the answer to that is probably yes, but without being able to evaluate specifically what's going on in your face, I wouldn't be able to give those kinds of answers in a webinar type of format. Every face is different, even before paralysis. We identify each other by our faces. Each one of us has a different face. Every face, every surgery, every viral infection, and every recovery is unique. And so every person requires and deserves an individualized evaluation and treatment plan. So in summary, neuromuscular retraining for facial paralysis is very much a patient-centered program. It provides excellent continuity of care after the onset of facial paralysis. It's cost-effective in that most of the therapy is done by the person on their own at home. and it provides the specific training needed for the unique characteristics of the facial neuromuscular system and the role that it plays in our humanness. It is the common wonder of all men how among so many millions of faces there should be none alike. I thank you so much for tuning in today, and I hope this was beneficial, and I hope you learned something new. And if there are some resources that I have here on the screen. Of course, the Facial Paralysis Foundation, who, thank you, Lisa, is hosting this webinar today. The Bell's Palsy Information Site, the Acoustic Neuroma Association, which many of you I feel are probably familiar with, the Mobius Syndrome Foundation, and Facial Palsy UK has a wonderful site with a lot of information on facial paralysis. I can be contacted at this address, and thank you very much.
Thank you, Jackie. That was a wonderful presentation.
Thanks.
Wonderful. We do have our questions box on now. If you would like, go ahead and type, like I'd asked before, if you are from another country, go ahead and type that in quickly. And if you did type a question in the questions box, I will submit it to Jackie, and we'll, like I said, we'll do a follow-up session probably here in the near future with your questions. So this will conclude our webinar today. A recording of today's session will be available probably by this weekend on our website, facialparalysisfoundation.org. Thank you again, Jackie, and also Brian, for helping out today. And thanks to everyone who took their time to join us online.
Thanks
See you
so
soon.
much.
Thank
Okay.
you so much. Bye-bye.